Okay, great. Thanks, thanks, Stephanie. So I recognize many names on the chat already. So it's great to chat with you all. So I'm Chris Tomlinson, staff physician here at Sick Kids in the NICU, and also one of our transport staff neonatologists working closely with the ACTS team. So we've, as you know, been getting many calls about bronchiolitis in very young babies this year. So that's what we're here to talk about today. And I'll just pass this over to my colleagues just to introduce themselves. On my screen, Sophan, you're next.
Oh, okay. Sorry. Hi, everyone. I'm Sophan Kang, and I am the NICU RT educator. And some of you may already know me from a lot of the outreach educations I've done with KHA and also at your centers before COVID, obviously. So nice seeing you guys all again.
Hi, I'm Estelle Goda. I'm the head of the Division of Neonatology here at Sick Kids and also a staff neonatologist, and likely have spoken to some of you during my nights on call or days on call. I'm very happy to have the opportunity to share our thoughts with you with some real cases that we received from you, and looking forward to the conversation.
Okay, so let me do the screen sharing. Hopefully it works. Can you guys all see that okay?
Not yet.
Not yet.
Oh, but it's coming. It's coming. There you go.
Okay, great. Okay, so we're going to start off with our disclaimer. And so I think, as Stephanie said, we're happy to answer questions throughout. We've aimed our discussion for our presentation for about 40 minutes or so, leaving plenty of time for questions at the end. So if you want to wait till the end for questions, that's great. And if you put them in the chat, we'll try and monitor those as we go along. So as we said, we're going to talk about bronchiolitis in neonates today in a case-based scenarios. And the three of us are all based at the NICU here at Sick Kids. I would really like to thank Erin Hesse, who is one of the residents here at Sick Kids, who worked on many of these slides with us and did a great presentation for us internally here last week. And also Michelle Saenz, who many of you will know as our ID specialist here, who's been very busy with COVID and now also with RSV, of course, who provided much of the data that we'll be discussing. So I'm going to discuss, I'm going to get things going and start a little bit about bronchiolitis epidemiology and present some of our current data. And then we've got two cases, one around focused on respiratory, non-invasive respiratory management. And the second case, spoiler alert, it's not all RSV. And then conclusion and discussion. And we're really happy to take any of your questions. So we're focused today on what is different, but also the same in bronchiolitis in patients less than 28 days corrected age, so true neonates, and look at the current guidelines in that age group. Also, we're going to review our current bronchiolitis epidemiology and a focus on the non-invasive respiratory support for those patients. So we're all very familiar with bronchiolitis, and pathologically, it's obviously an inflammation of the bronchioles, but in pediatrics in particular, we use it synonymously with a viral lower respiratory tract infection. It's largely a clinical diagnosis based on the history and exam and the history. We've all worked in pediatrics for a very long time. We've seen many of these patients, and they have a very typical course with starting with coryzal symptoms, progressing over a day or two with increased work of breathing, leading to poor feeding and indrawing. Signs of wheeze, crackles, leading sometimes to dehydration and ultimately to hypoxia. In North America, it's very seasonal, as you all know. Typically, RSV is the most common pathogen, peaking through November and April, and that accounts for somewhere between 50 to 80%. Also in the winter are the other coronaviruses and also flu from November through April. And then other viruses can cause bronchiolitis at different times of the year in North America. It's common, you know that. We've worked in pediatrics for a long time, some of us in particular, and it affects roughly about a third of children in the first couple of years of life. Most common cause of hospitalization in the first year, and with up to about 3% of children requiring hospitalization for the diagnosis of bronchiolitis. In Canada, as I just mentioned, typically the RSV season is between November and January, and that persists for about 4 to 5 months. And it's expensive. It's common, and there's a lot of admissions. It costs the healthcare system, and this is US data. It's always easier to get financial data from the US, but it's expensive, and you can see those costs there. Now, what's interesting about the costs actually is that it's getting more expensive to treat these patients, and that's largely because more of them are being admitted to intensive care. It's not clear why that should be. Is the disease getting more severe in itself? And this is data pre-COVID, as you can see there, showing that the number of patients that are being admitted to the ICU is actually increasing. But about 20% of children hospitalized with bronchiolitis will need an ICU admission, but only 3% needing actually invasive ventilation, about 5% needing some form of non-invasive support. So all this data, of course, is prior to COVID. And this is our just sick kids data showing our admission pattern over the last 8 years. And I think this is, we're all kind of anecdotally aware of this, but it was really interesting for me to see this data actually laid out in graph form like this. So in the light green, we have RSV admissions, dark green is the influenza admission, and the blue is COVID-19. And you can see that, as we know, we get a very seasonal pattern, starting with RSV in November, then peaking with flu, maybe a month or two afterwards, and everything tails off in the spring. And then, of course, COVID-19 comes along in the spring of May 20, and the other viruses essentially disappear for about 2 years. I think this is the Delta peak here in COVID, and this is the Omicron peak in COVID at the beginning of this year. You can see there was a little bit of RSV last year, but flu has really been absent until now. And then as COVID has been falling, and as we've been getting back to normal life in society, you can see that RSV has really gone through the roof, as has flu as well. And these, the start of this season has been much earlier. It's been starting in September of this year. I think this is all that we're anecdotally aware of, but it was really interesting for me to see this data actually laid out and see that this is actually what's happening in practice. It's not just in Canada this is happening. This is data from the US. And so you can see here that these are the older data from 2018, 2019 for RSV, showing a typical peak starting around November, December, peaking in January, and then falling. And then you can see that these are the seasons of 2020 to 21 and 21 to 22, which were really flat for most of the year. But you can see that this year we've taken off much earlier. And this is probably incomplete data from November and December, and I suspect these are still continuing to rise actually, but the season is already higher and has started earlier. And the same also seems to be occurring for flu. This is Ontario data, and you can see that typical pattern in 2018, 19, and 19, 20, and then really nothing in 2021, completely flat, and in 2020, 21, 22, a small peak. But now in 22, 23, we can see that the peak has started and influenza is really going up. So I think this is really reflecting what we are all seeing throughout the healthcare. It's all over the news, etc. And I'm sure you're all seeing this in your own practice, that the amount of bronchiolitis is much higher than even if we can remember to our pre-COVID years. And this is our sick kids NICU data, which really gives us the same sort of pattern. So in 2019, the last pre-COVID year, up until December, we had 14, or including December, we had 14 admissions. In 2020, we had nothing. 21, we had 4. And then so far in 2022, we've had 24 patients on this, or we're not, this is probably incomplete data in December, and we're only in the second week of December. So this number is obviously going to rise. The pattern of illness may in fact not have changed significantly. So mostly RSV pre-COVID, and it's still mostly RSV, but there is, we do see that there is some influenza starting to come through as well. So these our admission to the NICU is at Sick Kids has increased largely to an increase in the number of RSV and other viruses as well over the last few months. And again, the season does seem to, be starting earlier. So epidemiology of the bronchiolitis in 2022 is that the RSV and influenza outbreaks have started earlier. They're peaking higher. I think we've hoped that we've reached the peak of RSV, but it's likely that flu has still to peak. If what's going to be interesting, and maybe we're only going to be able to see this in retrospect, is whether the actual disease severity in the children has changed. I suspect it probably hasn't, and that these viruses are causing the same illnesses that they did before. It's just that there are more patients requiring admission to hospital. What we may end up seeing is that there are younger patients. So we have certainly, as you saw, admitted more patients to the NICU here at Sick Kids less than 28 days. And there's a couple of reasons why that might be, and this is a bit of hypothesizing here, is that, as you saw, in practice, we've had none of these viruses circulating in the last couple of years. So there's a big toddler pool of older siblings to infect the new babies that are coming along now. And then the other thing is that we probably all get RSV every year. It's one of those colds that we all get. And so pregnant women also get RSV. They make antibodies to them. And then given that they haven't been able to do that because RSV has been circulating at a much lower level, it's possible that the younger patients are more affected because there's not the transfer of transplacental antibodies or antibodies in breast milk to the younger patients. That's a hypothesis, and hopefully we'll be able to demonstrate that with data over the next year or so. Of course, this is now having a significant impact on the healthcare system and staff, as you all are well aware. And I will say that it has been amazing to see everyone step up, and many of you that are on the call that I saw join have been keeping patients on CPAP, on high flow in your NICUs, and readmitting patients from home to NICUs to isolation rooms, which I know that you didn't do before. So this is, I think really everyone has stepped up to cope with the huge demand on with the number of patients that are requiring hospitalization with bronchiolitis this season. So on behalf of us all here in the NICU at Sick Kids, and also at Sick Kids, thank you very much for doing that. So our first case really is a very typical patient. It's a 30-day-old late preterm infant born at 36 weeks gestation, presents to hospital with respiratory distress, lethargy, and poor feeding. There's a 2-day history of coryzal symptoms, but no fever. And there's a 2-year-old sibling at home who is also unwell. On examination, when you examine the patient is tachypnic, tachycardic, saturations are in the high 80s. Patient is afebrile and blood pressure is fine. There is, however, severe respiratory distress with subcostal and intercostal indrawing. There's grunting. There's bilateral wheeze when you listen. The patient's a little bit dehydrated with a sunken fontanelle. So you start heated high flow at 2 liters per kilo. You give a saline bolus because of the dehydration. You try an epinephrine nebulizer with little effect. And then the patient starts having some apnea, but the gas is okay. You just change to this high flow to CPAP, and you call us on the ACTS team. In addition, there's a partial septic workup, and ampicillin tobramycin has started. The chest x-rays really shows a little bit of atelectasis, but no focal consolidation, very typical for bronchiolitis. So as you're all very well aware, there are guidelines really from all pediatric bodies around the world looking for bronchiolitis management. In particular, the CPS guideline, and the link is here. The AAP have similar, and Sick Kids also has our own guideline, and again the link for that is there. What's important to note about these guidelines is that they are all based for patients from 1 to 24 months of age. And the guidance in that age group is really quite clear. So our challenge then is how to adapt that guidelines for the younger and higher risk patients. And the risk factors for severe disease are, the main ones are here. So age less than 3 months, congenital heart disease, a history of prematurity with or without chronic lung disease, but chronic lung disease certainly makes it worse, and any immunodeficiency. So these are screenshots from our Sick Kids guideline, and it's easier to start off with what we know doesn't work. So not indicated for investigations for patient with bronchiolitis or chest x-rays, blood work. Nasopharyngeal swabs really are not that necessary in season unless it's going to help with cohorting of the patients. What should not be offered as treatment are nebulized epinephrine, nebulized hypertonic saline, salbutamol, steroids, and physiotherapy. Antibiotics we'll discuss, I think, separately a little bit later. I'm also old enough to remember giving ribavirin, nebulized ribavirin to patients with RSV, and that fell off the cards a long time ago. So in terms of what we should be doing in treatment is oxygen and hydration, nasal suctioning, not routinely, but certainly when the patient appears congested, and not recommended are all of, in addition to what we just said, coolness therapies, antivirals, and the respiratory support is really what we want to move on to next. So I'm going to pass things over to Sopon to discuss our different respiratory management patients for this patient.
Perfect. And thanks, Chris. So I will say that a lot of this has already been covered for peds in terms of oxygen therapy and heat high flow therapy. And my main focus isn't really, unless you have questions after about adapting some of these technology, my main focus right now isn't really to talk about how to apply and the mask and all this other stuff, but actually what differs between for our babies less than 1 month versus the pediatric, because you may start to see some differences. And I know that some of the stuff that we do here and may recommend may be a tiny bit uncomfortable, but I just want to kind of lay out why we do some of the stuff we do here. So from the right side, you can see there that's oxygen therapy, and that is the lowest support for any baby who needs oxygen. But you also know that that's dry gas and it's cold dry gas. So here it says flow less than 2 liters per minute, but for us really, babies who are on oxygen therapy, it should be only maximum maybe 500 cc, 500 mil, because if you need 500 mils or more, something else is going on. So just kind of reassess why that might be. And then moving, what some of our main focus today is more on heated high flow and then on the CPAP. So Chris, can you, next slide? So heated high flow, just the mechanism of action for heated high flow. A lot of you are already aware, but just to, the humidification, we got cold, dry gas. When you're giving cold, dry gas that are higher than the baby's minute ventilation, and that's very important, is to actually set the flow higher than the baby's minute ventilation, you're going to need humidification because it's going to be more than what the baby can actually do on their own. The other important thing is to have accurate FiO2 delivery. So because we're setting higher than the baby's own minute ventilation, and that includes workup breathing. Remember, their workup breathing and increased respiratory rate and increased tidal volume also means that they have a higher minute ventilation. So we're setting high flow higher than that. We are able to avoid any entrainment of room air and any of that natural blended that happens and be able to actually give accurate FiO2 delivery that we could not do with low flow. For the other part, why high flow actually works really well for our neonates too is because of the dead space washout. So anatomically, babies and younger peds have very high amount of dead space, anatomical dead space compared to their lung size. So a lot of time when they're working, they have that stagnant air that actually doesn't get to be cleared, and therefore it taps on to the next breath, and that's why their worker breathing just seems to get worse and worse. And then they get like CO2 rising and all that stuff that you do see. And this is where I get a lot of question in regards to pressure. And I do want to say that, yes, because of the equation, flow plus pressure, we do innately, because of flow, will get pressure, but I want to remind everybody that this is dynamic. So the dynamic pressure, meaning that in CPAP, where we have a seal, in high flow, the prongs are only going to be about 1/3 to 50 to a half the size of the nair, and therefore you don't have a seal system. And based on the baby's respiratory rate or tidal volume, you will not get a consistent pressure. And then if the baby cries and all that stuff, that pressure will actually drop. So again, the higher the flow, yes, you may get a higher pressure, but again, just to remind everyone that it is not a constant pressure, that this pressure is dynamic. Next slide. Okay, so what I did here is just to kind of follow suit with what Katie did in the pediatric side of things, is to create sort of like this is just a suggestive flow diagram. You're welcome to screenshot, you're welcome to actually help you navigate and guide on what to do with heated high flow nasal cannula. So some of the indications are on the left there, and I'm not going to speak too much, but the biggest thing is that heated high flow nasal cannula is one of our primary line of defense for bronchiolitis. We're really happy we've been able to avoid CPAP and intubation for some of these babies that we would have done in the past, simply because we're actually going up on higher flows on our heated high flow nasal cannula. So similar to the pediatric side, we do start at 2 liters per kilo per minute, but with a minimum flow of 3 liters per minute total flow. So basically, if your baby is 2 kilo, then you're going to start at 4 liters total. If your baby is 1.5 kilo, you're starting at 3 liter total. And we usually don't go below 3 liters total, but you're not going to get tiny babies anyways. From there, we look at response, whether they improved or not. And then if they improved response, sit on them for a little bit, see how they do. And when they get better, the weaning process, I'll talk about that in a second. In regards to response, if you don't get response right now, we are advising you to call first. So you can call and talk about the situation, but what you can do as a bridge in between also is you can start increasing flow. And we do increase flow up to a maximum of 4 liters per kilo per minute. And then of course, make sure you observe your equipment limit, but we'll go in about 0.5 to 1 liter per minute every 15 to 30 minutes until the baby's worker breathing decreases. This is a call at wait and titrate to effect method. And then of course, if you don't see a response by the time you get to 4 liter per kilo per minute, make sure you do call, and then possibly at this point in time, we'll need some CPAP. So this is all, don't forget to reassess, and we're continually reassessing and then monitoring these babies. So I just put a disclaimer up there. There's an OG, make sure we have an NG or an OG, possibly an OG, better if you're using a mask. And then just to get some of that gastric air out also on top of this is going to be different, possibly from the recommendation from the pediatric side. And there are many things as to reason why that I can't get into this, but this is a practice that we've been doing for a very long time. And this is the current practice we also recommend through our KHA counterpart as well for the community partners. In regards to weaning, we do recommend weaning FiO2 first before you wean your flow. And then based on comfort, you will see the babies after their course, and RSV course is around a few days, you will see them actually do really better, and they'll change that course, and then weaning may be faster. But this is if you're a little bit cautious, you can slowly wean if you want to, and then get to the point where you're at 2 liters per kilo per minute, the baby looks good, and your FiO2 is less than 30%, you may just be able to take it off and actually put onto some high flow there. Next slide. This is for some CPAP, and this is for guideline only, and I'm only saying this as a start, and I want to just kind of put that disclaimer too, that these are just, again, respiratory management is sort of like experience and some spidey sense too. So just want to always call critical to consult with our tertiary center or ask if you do have any reservation. And I know that some of you have been keeping some CPAP babies. So I just want to kind of give some guiding principle around that. So FiO2, we do set our CPAP level based on FiO2 plus work of breathing. So it's very subjective in terms of work of breathing. And especially in the bronchiolitis, you do have higher work of breathing, and some people are a little bit more tolerance of some certain amount of work of breathing, and some aren't. So in terms of guidance, if you have high FiO2, it's just obvious that you do need higher CPAP. And I'll talk about hyperinflation at the end question if you guys want to ask that, but these are just some of the guiding principles. And this is just starting level, and then you can titrate down or up based on the baby's, how the babies look. And then definitely please call back if your CPAP the baby's not improving on CPAP of 8, and if your FiO2 is still greater than 40%. The next slide there, Chris. I really want to give a big caution around nasal interface. I presented this at the T4 Health Conference many years ago. This is a study that was done in 2019. And basically, the number isn't everything. Sometimes you may have to actually go up on certain numbers to get what is equivalent down into the baby's lungs because of the resistance across the interface. Very caution around RAM cannula. It has a lot of back pressure. So if you're using RAM cannula for CPAP, I do want to give that caution that it has a lot of back pressure, and the number that you set on your CPAP level may not actually be what the baby is receiving. Our thing here is about 2 centimeter water. If we want to put a CPAP of 5, we'll set it to 7, and it's about that for a lot of the studies that we're doing around RAM cannula. Other seals, remember that mass has less resistance than prongs, and depending on the smaller the diameter of the prong, just based on Posseel's law, the smaller the diameter, the higher the resistance. That's all. So it's not focusing so much always on just the number, but also what the baby looks like and maybe getting. Okay. And then the next slide, and then just continuing monitoring and assessment. Don't forget to suction, remove any obstruction. These babies, if they are on longer term, which I hopefully not, just because for the RSV course is not, is making sure we check on the skin integrity. Biggest thing for us really is minimal handling. The baby just kind of like doing less is more kind of thing, and providing comfort. And of course, always you can consider prone positioning if the baby tolerates it. Sometimes they look like they want to swim though. And then yeah, and I think after this is Chris, back to some hydration.
Thanks, Sophon. So the other, what we should be doing: oxygen, respiratory support, and hydration. So I think you're all probably quite familiar with this. So maintain use the enteral tract if it's possible. So feed via an NG or an OG tube if the patient's able to tolerate that. Although probably will need to be NPO initially if is on respiratory support. These are young patients, but we are advocating to stick to the 4-2-1 rule and use a TFI of about 100 mils per kilo per day as maintenance for these patients. And our starting off fluid that we're recommending is D5 with normal saline and following the plasma sodium as needed. As many of you know, my background is nutritional sciences, so I feel I have to put this in, although I don't think anyone would really do it, but there's no indication for parenteral nutrition in these patients. This is a short-term illness, and we should be introducing enteral feeds as early as possible, and EBM is ideal, and certainly back to oral feeds as soon as the patient is able to tolerate that. What we're finding particularly challenging in the younger infants is antibiotics. And if they have a viral bronchiolitis, of course, antibiotics are not indicated for that. And that certainly sticks with the guidelines of the 1 to 24 months. In practice, though, it's very difficult, and there is certainly it seems to be a conflict between bronchiolitis guidelines for no antibiotics and the febrile infant guideline, which will advocate for a full septic workup and empiric antibiotics in the presence of a fever of neonate. Our Sick Kids guidelines for the well-appearing infant at 22 to 60 days certainly does have a caveat if there are symptoms consistent with bronchiolitis in the bronchiolitis season, that we don't necessarily need to do the full septic workup. I think we should be doing urinalysis and getting a urine culture, because that can certainly be occult in these patients. However, I think we are taking, and I'll be honest, a pretty pragmatic approach to the use of antibiotics in our patients that we are seeing in the unit at less than 28 days. Many of them are getting a CRP and white cell count, and if they are increased, we are generally starting antibiotics, and particularly if there's focal consolidation on X-ray. And almost all of our patients are getting X-rays, of course, but to get in here, they're already on significant respiratory support. We're generally advocating for cefotaxime, but if the patients are following that typical course, they are, for example, RSV positive, they are getting better after a couple of days, then we're not continuing that course. We are advocating to stop after 48 hours when the blood cultures are negative. So our case was transferred here, and the viral swab did come back positive for RSV. Blood and urine cultures had been taken, but they were negative, so the antibiotics were stopped. A short period of CPAP was needed for about 36 hours, but that was much better, and he was weaned to low flow after 24 hours, and then to room air. Hydration was maintained with NG foods and IV fluids, and on the day of discharge back to actually discharged home from us, and we are actually seeing that these babies are improving very quickly, typical for RSV, and are actually going home from our NICU rather than back to a level 2 on occasion, and was discharged on oral feeding. And so I'm just going to pass things over now to
Chris, before you do that, there's a question in the chat that I think is relevant. So one of the Claudia Garcia Galvez, I apologize if I didn't say it correctly.
Yeah, hi Claudia, how are you? Good to hear from you. So
do you see the question? What about
so the question is, should we be using D10.2 or D10.45 for IV fluids? So what we've found actually is that our patients are actually getting hyponatremic with those solutions. So they are quite hypotonic, the 0.2, 0.45. And so we are starting with normal saline and then following the plasma sodium. And we've actually found that it's not, the plasma sodium has maintained within the normal level with that. So we're giving the TFI of around about 100, and then using the fluids containing normal saline to make sure we are not allowing these babies to become hyponatremic. The glucose content, I find in practice, most centers have D5 normal saline. They don't usually have D10 normal saline. I think that's fine as long as the glucose is maintained. And we can certainly go up to D10 if there's hypoglycemia.
Okay, if there's no more questions related to that, or I might ask, do you think that the hyponatremia associated with the lung disease might be secondary to? What are your thoughts on that?
So I think that there may well be SIADH in some of these patients. So I think that's why I think it's important to not to treat them, they're neonates, so not to give them too much fluid dose, so stick to the 4-2-1 rule, give them maintenance is 100 mils per kilo. I think that we actually feel a little bit anxious about that in the NICU. We're very we're in our habits of giving, 140 to 150 mils per kilo per day. I think that's too much for these patients. I think they should be getting 100. We can follow the plasma sodium, and that's why I think that we should be sticking to the normal saline to make sure we're not giving hypotonic fluids.
but your baby came in dehydrated. So he did get a 20 cc per kilo bolus of fluid prior to that. Okay, sounds great. Okay, well, you had a very good baby, responded to therapy. That's fantastic. I'm going to basically do case 2, which is also a baby that came from a community hospital. Presented at, it was a 21-day-old infant born at 38 weeks, uncomplicated pregnancy, everything was going pretty well. He had a 1-day history of nasal congestion and some respiratory distress and poor feeding. And when he was seen at the community hospital, he had a cough, no fever. And of course, he had 4 siblings and they were all sick. And the 2-year-old actually also had vomiting and diarrhea a week before prior. So when this baby was seen at the community hospital, even though he had poor feeding, his diapers he was wetting and urinating well, he appeared to be well hydrated, but they described him as having pretty subcostal and intercostal indrawing with moderate respiratory distress. They do describe that the baby had crackles bilaterally. They did a rapid COVID, it was negative. The CO2, and I just point this out, we could talk about it later, but on the electrolytes was 27. The CRP was 57. The white count was 8.8, and he had a low neutrophil count of 1.5. Lymphocytes was 127. And the blood gas at that time was they put the baby on 1.4 liters of oxygen of low flow, and he had a pretty good blood gas. pH is 7.42, PCO2 of 38. The bicarb again on the gas was 24, but they described the X-ray as being clear. I'll show you that in a moment. Then they continue to follow the baby, and about 4 hours later, they noticed that the baby was having more desaturations. He transitioned to high flow. He continued to have problems. Then he went to CPAP of 6 or 7. FiO2 went up to 70%. They did another blood gas, and the baby had significant respiratory acidosis with a pH of 7.06 and a PCO2 of 96. At that time, the community hospital went on to give RSI, intubate the baby, and then the ACTS team was called. In transport, the baby was sedated. Here's the chest X-ray on the, I guess, my left, of what it looked like before the baby got intubated. And I think there was one even before this that I don't have it, but the first one was really described as being normal. But you can see that there looks like there's some consolidation here on the left. When the baby presented to Sick Kids, which wasn't too long after the baby was intubated, this is what the chest X-ray looked like. And it was read as density in the left lower lobe and right upper lobe, consistent with consolidation. When the baby they had already started antibiotics at the referring hospital. When the baby presented to us, however, the baby's white count had dropped to 1.4. He certainly had significant neutropenia and an IT ratio of 1.45. His hemoglobin on admission was 120, but 24 hours later, the hemoglobin had dropped to 98. The CRP had risen to 143. And from a respiratory standpoint, the baby did go up on relatively moderate settings on the ventilator, but then had an intubated course of about 4 days, was extubated, and then went on CPAP. What was perplexing to us was that the baby had such a high CRP. It looked like this was definitely pneumonia, although certainly the baby can have a viral pneumonia that can look like a consolidation as well. But because of all these extra findings, we did a tracheal aspirate and the baby grew out Haemophilus influenza. So we diagnosed it or worked with the diagnosis if this was a secondary bacterial pneumonia that the baby had, and thus was treated with 7 days of antibiotics, and I believe it was cefotaxime. Do note, however, that our viral panel at Sick Kids, of which you can see we just check for just all sorts of things, and this baby actually had parainfluenza, which was detected and not RSV. And although this looks like COVID, his COVID test was also negative. If you can go to the next slide. So I think this baby shows that what are the indications for intubation. I'm sorry, maybe you could comment on this one also. Okay, I'm sorry. But so the baby had apnea. If the baby has an indication for intubation, if the baby has apnea. I'm going to show you a paper who actually did a large cohort prospective study of what are the predictors that a baby will present or then evolve into apnea in a moment. Respiratory failure, certainly this baby met it with all, with the significant respiratory acidosis, and his FiO2 had gone up to 70%. So our guidance would be for a baby who continues to do poorly, has increased his FiO2 to 40%, has respiratory acidosis, and still has significant work of breathing, that's sort of the indicator for proceeding with intubation. Next slide. Maybe you don't think a lot about parainfluenza. I certainly didn't, and parainfluenza is not influenza, but I'm going to just remind some of the people on the audience of what this virus does. Actually, it's the major cause of croup and not necessarily bronchiolitis. It gets into the airway just like the rest of them in the nose and then descends down. It is not common that the babies will have leukopenia and neutropenia unless, in fact, it is infecting children with malignancy. So this baby definitely was different. The other things that it can cause is bronchiolitis, and this is sort of the hospitalizations, about 0.4 thousand for babies who are with croup will get admitted with the serotype of 1 to 2, bronchiolitis, and pneumonia is the serotype 3. And I didn't get a chance to look at this baby's serotype, but could do that. And I would not put money on it, but would predict that this baby probably had a serotype 3 plus the bacterial process that was going on. So 50% of the kids with parainfluenza will just have URIs, of which of interest, especially to our community physicians, about 30 to 50% also have otitis media. So even though we suggest that you don't put babies on, and it could be a viral otitis that doesn't necessarily need antibiotics. So just to, I don't think we have an otoscope in our NICU, do we, Chris? we should be using it. About 15%.
We can find one somewhere.
Yeah, we need to find one for sure. About 15% of the babies with parainfluenza will get involved the lower tract of children. And they're the bad non-respiratory complications that certainly can happen that you see there. But again, unless the baby is progressing, the treatment is supportive. There are no antivirals, and ribavirin is not used. Of interest, breastfeeding and pneumococcal vaccination has been associated with reduced risk of severe infection, mostly because it's less likely that they will get a pneumococcal pneumonia, and there's antibodies in breast milk. Next slide. We were in the middle of the Omicron wave. Some of the babies that we took care of here during the January Omicron wave came from your community. We had not seen essentially any neonates with COVID in our NICU. And from January to February, we had this big spike within a week of having 5 babies admitted with COVID. I was just going to briefly show you what that presentation looked like. Can we see that? We've submitted this for publication, but of interest, I wanted to point out that similar to the other viruses, our babies can present with apnea. 2 of the 4 did. Was pretty significant apnea, and actually this is the reason why the babies got intubated, and not necessarily for respiratory distress. The other important thing that I want to sort of point out to you is that for COVID, not the other viruses, if the baby has progressive respiratory distress, we need to know about it, and more than likely the baby needs to be admitted and transferred to sick kids, because early intervention with dexamethasone and remdesivir is really sort of the treatment for some of these babies, particularly those who might be getting intubated and not getting better. But steroids are not indicated for the other viral processes. And if there's a question related to that, I can sort of address that. Next slide, please. I thought it was very interesting what babies are at risk for developing apnea with the viral infection. And this was a very nice paper that was published in Pediatrics of 2013. The reference is down there, or the citation. But they found that this was a 2000 child prospective study in which they saw that a corrected age of less than 2 weeks and between 2 and 8 weeks was the odds ratio was quite high, 9.6 and 4.7 respectfully, versus those babies who are greater than 6 months of age. If you were less than 2.3 kilograms at birth, your odds ratio was twofold compared to the baby who in fact was 3.2 kilograms. Also, if the baby had had a bronchiolitis episode in the past and had apnea prior, then it was very likely that the baby, if he had a recurrent bronchiolitis, was very likely to have apnea as a presentation again. I thought this was very interesting. The pre-admission respiratory rate of less than 30 had an odds ratio of 4 for that baby to get intubated. Or if the respiratory rate was between 30 and 39, had a 2.2 odds ratio of that baby getting intubated, or if the respiratory rate was over 70, compared to a normal respiratory rate of about 40 to 49. And also, if the baby had a pre-admission room air saturation less than 90, it was likely that that baby would have some apneic episodes. And then the little graph down at the bottom just simply says that RSV, Haemophilus, I guess an adenovirus, parvo, parainfluenza, influenza, pretty much all of these viral infections can be associated with apnea. And the important thing here is the black bars are apnea versus no apnea, that there really isn't a big difference, but one can see that all of with the higher incidence of RSV, but really you can see that all of them can have to present with apnea. And the next slide. I thought I wouldn't go over this unless someone asked me, why do you think they're having apnea? Because I want to leave time for questions. So I think we will conclude here and move on. You can take it, Chris.
Yeah, so thanks, thanks, Estelle. So I think in conclusion, there are I don't really believe there are major differences in the management of bronchiolitis in less than 28 days to the 1 to 24 months. These are, though, very high-risk patients, particularly for apnea, and many of them will need respiratory support and admission to the NICU. I think I would advocate for a very pragmatic approach to antibiotic use. I remember when I was doing my pediatric training, if we started patients with bronchiolitis and antibiotics, we really would get hauled over the coals for it on the ward round the next morning. In a patient less than 28 days, no one is going to be critical of you for starting antibiotics. I think we need to be quite pragmatic about that. But the bottom line is that it's supportive care. It's oxygen, respiratory support, as Sopon mentioned, and hydration that are the key and the mainstay for this treating this condition, even in these youngest infants. So thanks very much for listening. There's a couple of questions in the chat that we'll get to, but feel free to come in with any questions if you have. So Claudia is asking, I'm just going to go through in order as I'm going up here, just as I see them. So Claudia is asking about nebulized salbutamol and when there's a history of asthma in the family. Again, there's quite strong evidence to show that either nebulized salbutamol or epinephrine does not make a difference to these patients. So I would not be advocating for that, even with a history of atopy in the family. Estelle or Sopon, if you disagree, then please.
No, I don't disagree.
No, I agree with that too.
So Sarah, are you able to unmute and just ask your question? So I'm just
Yep. Yeah, so my question was, is there an age, and you wouldn't necessarily see this, but where you would automatically admit a baby with RSV due to the risk of apnea, which may go undetected. So I tend to use a cutoff of like 4 to 6 weeks corrected. And if they come in with symptoms, whatever, to emerge and they test positive, I have a low index or threshold to admit for observation for a period of time. Just to that concern, I just wondered what your thoughts were on that.
Estelle, do you want to?
I think that is the better part of valor, that you should be able to observe the baby. But I think if the infant, some of those parameters in which we just talked about, if the baby is having an appropriate respiratory rate, if he's a post-preterm baby, I would be worried about the baby presenting with apnea. Usually, however, apnea can occur early in the course. And then they get more of the bronchiolytic increase in respiratory distress. But to answer your question, I think at least a 4-hour observational period would be appropriate. It'd be unlikely that the baby, if he's getting better, is going to develop apnea 24 hours after your presentation, if he's getting better. Chris, do you have some thoughts?
No, I just brought up your slide just on that issue there, Estelle, just like so there are, clear risk factors for development of apnea. So the younger the baby is, obviously, if the baby was preterm and low birth weight. What I actually was not aware for until we were preparing for this chat was the pre-admission respiratory rate. So the evidence, I guess, this would be of hypopnea, may be a risk factor for actually developing apnea. So I think that's quite an issue. So I guess, Sarah, what we're saying is if your patient in front of you has these risk factors, then sure, a period of observation would seem appropriate.
Any other questions?
Anyone else either type or just shout out? Well, don't worry about it.
There is a question about is there an age corrected, or is this the same?
I think that was Sarah's.
All right. Okay.
Yeah.
Well, it'd be interesting, Sarah, to know what is your experience when you said you tend to admit under 4 to 6 weeks when they come in and test positive. I guess that paper would suggest that certainly under 2 weeks is certainly something to be concerned about. 4 to 6 weeks is probably right there in the cusp. But what is your experience, Sarah? Do you see that these babies go on to develop apnea?
Some of them do, and one of my philosophies is what allows me to sleep through the night. And so with apnea, sometimes it's hard for people to detect that, like a baby. And so I just have a low threshold. It all depends on bed availability, etc. But sometimes a period of observation, depending on what day of illness they're on as well, because we know that the trajectory of RSV is that it's worse on about the 4th or 5th day. So if I know they're past that, then I'm more reassured. But if they're early in their course, I might, be a bit more worried and warn the parents, because sometimes parents come and they think everything's fine, even though they have to be told they might get worse before they get better.
Right.
And that frequently happens, and giving them that out to come back if things aren't going well. But again, the younger they are, the lower my threshold is to just admit them so that I can watch them. And if they're great, they're great. But sometimes they start to have spells, and sometimes, or other times you watch them, they're fine in room air, you send them home in the morning and they come back 2 days later and need high flow and CPAP, etc. So it can go both ways. But.
And how long are you usually admitting these babies for if they're not, let's say they're stable for 12, 24 hours? Or
yeah, it would depend on the day of their illness, and their age and other risk factors. So of course, if they're a perfect peach, you're not going to keep them as longer. But I have lost, sent them home and they're just too early in their course and they come back like an ex-prem and need to go to sick kids, etc. Yes. And so, but it's just one of those things that I think about. And again, the rapid test is not always perfect. So you do have kids who have RSV who don't test positive, and just because they test positive, are they any better or worse than another kid? So it's hard to say. We have
also, I don't know if you're testing for the other viruses, but do note that they could have the other viruses, rhinovirus, a pair of influenza, which
and
can be similar.
And where we are, we don't get that back for a few days. So usually by that time they're better. And then I do call and let them know, like I just had a kid recently admitted with RSV, and they came back, they also had adenovirus and coronavirus all on as part of their illness. So it wasn't a neonate, it was a toddler, but there are a number of viruses going around.
Well, toddlers are literally into everything currently, as you can see. So, Pon, there's a question there about deep suctioning on high flow.
So again, so similar to what Chris said earlier, we do deep suctioning as needed. They'll sound really bad for a while, and it's very hard. As an RT, for instance, I have a hard time hearing it, and parents, and sometimes you always get the parents are the one who also it's really uncomfortable. But the problem is, the more we go down, the more we agitate them, the more they actually like don't get that rest that they need. So, and work up some more, and that's what we don't want to do. So in the early course where they are very sick, we tend to go earlier, we tend to go more often, and it's more around, we hear it's worse, we hear it more than before, like it's kind of getting worse, and it's more for comfort measures, and then as they get better, we kind of stop. So our respiratory therapists and our nurses are able to deep suction, and I know it's depending on skills, but if you can get in a good deep suction in the morning, right off the bat, and then before you leave shift, get a good one before you leave shift, and maybe one more in there, I think you're doing good for deep suctioning. And when I say deep suction, I mean like down that nair into the back of that throat, get them a good cough and get that goober out. Like, it's so satisfying.
Okay.
It's nearly dinner time, but
I just want to make sure, are your staff comfortable with deep suctioning? Like, are they just kind of doing the tip and then going into the mouth only? I think that with bronchiolitis, that may not always be enough. We need to elicit that cough and kind of get it up and getting that out.
Our nurses don't typically deep suction, but the RTs will, and they are comfortable with it because they all work in NICU. But our babies with RSV on high flow will not be in our NICU. They'll be on pediatrics, even if they're 2 weeks old. The problem is, like, a lot of our nurses are not very experienced right now because they all, we have a lot of new people, and they might not know when someone needs to be suctioned. And anytime we call with a deteriorating baby, the first thing that we're asked on the bridge line is, did you suction? So I was just wondering if there was any rule, like how often they were supposed to do it. Like, sometimes I'll write Q4 or something, like, just so that they do it, but I don't know.
Yeah, it really depends on the baby. So I hate that word where it all depends on the baby, but so a baby who's at their worst and doing worse, we might suction every 2 to 3 hours, to be honest. That's a little bit earlier than what you may think of, like 4 hours, but that's at their worst. And then the Q4 maybe actually be enough, to be honest, with some of these babies who are kind of more of a mild to moderate type kind of RSV. And then as long as that was effective, I think it's more the effectiveness of your suctioning. If you get a good one right at the beginning and one right in the middle there, and then right at the end, like, you'll kind of see that you'll clear more through that way too. And then the rest of the time, just any tip suctioning that kind of comes up and clear their nose, if possible. And the worst case for sure is the one that you have to do at Q hour, but then that's really, that baby should be, something else is going, like, we really should be looking at what else is going on there. Does that help, Rachel?
Yes, thank you.
all right. Thanks so much. If there's no more questions, I think we're just over time. Thanks very much, everyone, for for listening and your attention. Thanks, Stephanie at Connected Care, for setting this up if there are any questions, then if you want to ask via email, then you know how to get in touch with us, and please do. We'll try and answer them as best we can. I almost feel like I should be taking on some sort of dad role here and giving everyone a pep talk that, you know, we're actually doing a tremendous job, but this is, it is unprecedented, the number of patients like this that we are seeing, but we're managing, we're coping, and I think we are actually working well as a healthcare team. So thank you all for your help and for looking after these patients. And I know that a lot of you really are doing things that you would not normally do, and readmitting patients to your NICU, putting them on CPAP. And so thanks very much for doing that. And it will be April soon.
It will be. Again, I would like to reiterate that and do thank our community partners, and again, remind you that we're always here anytime, 24/7. So a call just to discuss the case, not necessarily wanting to transfer, is also welcomed and appreciated. Okay. All right.
All right.
Good.
Thanks so much, everyone.